Welcome, viewers and listeners, to the Health Revolution, the program that shows you how to have a life of vibrant well-being. In a world full of noisy health trends, we bring you clarity. In a sea of fads, we reveal the science-backed strategies that truly work. We explore physical strength, emotional resilience, and mental mastery. These are the keys to an enriched life. Join us for inspiring interviews with champions who conquered life's health challenges, fueling your journey. Are you ready to unlock your potential? To live with vitality and purpose? Then join the Health Revolution. I'm your host, Adriana Morrison, health and fitness expert, speaker, and a mom who understands. Let's embark on this transformative quest. Together, we're about to change the game, starting now. The information provided in this show is intended for educational and entertainment purposes only. Viewers should use their own discretion and consult with a healthcare professional for personalized guidance and recommendations. Welcome, everybody, to the Health Revolution. We're excited to have you here with us today. I'm your host, Adriana Morrison, and no matter which way you are tuning into us, please do not forget to hit the subscribe button. We want to stay connected to you. In addition to that, we have important show notes that you are going to want to reference during and then after our show. So don't forget, at the bottom of your screen, you'll see a little tab where you'll see reference information. So we're getting into it. Today is all about saving lives. It is important that we continue to do all that we can to enhance lives. And yet, when we talk about CPR, when we talk about saving lives, only a fraction of the world's population is aware of how to help save lives. The medical technology that's out there continues to evolve, but in what direction can it truly help us? And so I'm excited about today's episode because we're going to explore that, and we're going to explore some solutions that we can really lean into. If you are in the medical space, if you're working in a clinic setting, in a hospital setting, please lean in and share this episode if you are catching the replay. Without further ado, I want to introduce to you my guest today. Have a look at this. Dr. Lyn Yaffe is the CEO of EPR-Technologies. EPR-Technologies is revolutionizing resuscitation practices. Their innovative approach to CPR is transforming emergency response, offering groundbreaking techniques for critical care. Dr. Yaffe's academic journey transcends from Johns Hopkins University to the University of Maryland School of Medicine, culminating with extensive research at Columbia University, and this has paved the way for his pioneering work in medical science. Dr. Yaffe and EPR-Technologies' focus is on enhancing CPR efficacy through rapid, profound hypothermia, a method that's proven to significantly improve outcomes in life-threatening emergencies. It's not just about improving CPR. They're redefining the future, setting new standards in life-saving medical care. Dr. Lyn Yaffe, I know you want me to call you Lyn. Welcome to the show. How are you, sir?
I'm doing fine. How are you? It's a pleasure to be here.
Yes, I'm excited. You know, this is such an innovative approach. When you and I first talked, I was astounded by how leaps and bounds the potential this is. Can you talk to us about CPR and the importance of CPR and why we're not doing enough these days?
Well, CPR has a very interesting history. The father of CPR is considered to be Dr. Peter Safar. And I worked with Dr. Peter Safar starting in about mid-1990s, about 1995. I worked with him at the University of Pittsburgh. Dr. Safar passed away in 2003, but prior to his passing and in the mid-1995s, he was interested in going beyond standard cardiopulmonary resuscitation and came up with the idea of emergency preservation and resuscitation, EPR, or rapid profound hypothermia. It's interesting that CPR techniques obviously don't work in every situation. In severe trauma, where the patient has massive bleeding that can't be easily stopped, the patient loses so much blood and they go into what's called exsanguination cardiac arrest, and they cannot be resuscitated. Many times people with sudden cardiac arrest without trauma, it's also difficult to resuscitate them using standard CPR techniques. It's noted that there are about 500 trauma deaths a year I'm sorry, not in a year, but 500 trauma deaths a day in the United States, and about 1,500 sudden cardiac arrest deaths. So that's about 2,000 a day. And for the trauma victims who need CPR, if you attempt to save them, less than 5% get saved. For sudden cardiac arrest, if that happens outside of a hospital, only at most 15% are saved. If you have sudden cardiac arrest in a hospital, if you're lucky enough to be in a hospital when that happens, about 35% get saved. And so really CPR techniques and options for enhancing CPR need to be provided and are worked on all the time. EPR got started, rapid profound hypothermia, because of the military's interest in saving lives on the battlefield. In wars since Vietnam up till the present, about 80% of those killed in action die from rapid bleeding. A trauma that gives rapid bleeding so fast that you go into cardiac arrest. And on the battlefield, there's really nothing that can be done for that. So the military was interested in what could be done to save those lives of those killed in action that can't be currently saved. And they spoke to Dr. Saffer, who I mentioned, the father of CPR, and he said one should attempt rapid profound hypothermia, meaning instead of trying to save the life immediately with CPR that doesn't work or any other techniques, what you do is present a situation where you prevent the casualty or the trauma victim from dying. So you don't worry about immediate resuscitation. What you do is cool the body down to 50 degrees Fahrenheit or 10 degrees Celsius. That's above freezing. We're not talking about freezing. I like to make that distinction. We're just talking about cold. At that low temperature, the body doesn't need oxygen for a period of several hours, at least 3 hours, maybe as long as 5 hours. And during that period of time, you don't have to worry about resuscitation. You don't have to worry about giving the patient oxygen or breathing. They're not breathing at that low temperature. You don't have to worry about chest compressions. The heart's not beating. You don't have to worry about oxygen to the brain because you've cooled the patient down. And at that low temperature of 10 degrees Celsius, 50 degrees Fahrenheit, what you've done is reduce the metabolic requirements of the individual. So there's still cellular life, but you don't need to resuscitate the individual because their oxygen needs and their metabolic needs are almost zero. And so that
let me jump in here real quickly.
Yes, sure.
So obviously this is profound in the medical setting. So can you connect the dots between, say the scenario of someone having a cardiac arrest or having a cardiac issue, and they're in a public setting, and so then it's discovered that they are that they're in needing of immediate care. How does, say, what is the transition like? Because I want to bring the viewer in who is the bystander and understands the gravity behind CPR. So I want to add context to the backstory. What is the timelines that we are looking at to just help? And then obviously I do want to go into the medical piece behind this advancing technology.
Right. When a trauma victim or a sudden cardiac arrest victim goes into cardiac arrest, really the sooner a bystander can start CPR techniques, and it's important for able-bodied people to know CPR, and you can go to your local Red Cross. They give courses all the time in order for anybody to become certified in in CPR. But in those initial minutes, the first thing you do, if you're the only person on the scene, you call 911. You want 911 to come. So you've got some professionals there to do CPR. But if you're a bystander, you start chest compressions and mouth to mouth. First, you do chest compressions. You try to do, 1 to 2, ideally every second. And you need to do deep pressure, on the sternum. Everyone has seen that done. And maybe every 15 chest compressions or every 15 seconds, you'll do a mouth to mouth breathing. So if you don't do adequate CPR for, let's say, 5 to 7 minutes, you really risk the patient having brain damage. So you have to make sure that you have adequate oxygen delivery to the brain. So it's very important between the time you call 911 and the time that they arrive, someone is there to do adequate CPR. You don't have a lot of time to fumble around. Obviously, if you're at a place where they have defibrillators and bystander use of defibrillators, you may have noticed defibrillators at an airport setting, and if you're the first person, you can open the window, take the defibrillator, and if you're trained in CPR, if you've taken a course, you know how to use a defibrillator. If you've never done it or tried it or seen it, you're going to spend time trying to figure it out, precious time. So hopefully at an airport, they're going to have someone who knows how to do it, who can be right in the scene. If it's an office building.
And just to add context for the viewer who's not aware of defibrillators, oftentimes they are in many large settings that they are available, like in a large building or many large buildings, even in gyms, in just a public setting where the traffic, the walking traffic is a little bit
more. In recent years, defibrillators have become public use defibrillators because they've been so simplified in terms of step 1, 2, and 3 and putting on the paddles and doing it. And people probably have seen them used on TV.
Hopefully so.
Yes, it's nice to be familiar with it. You mentioned office buildings. Usually if an office environment has a defibrillator, they usually like to have 1 or 2 people who are highly trained to use it. Everyone should be familiar, but if there's an emergency, that trained individual at the office can do it. It's also, I always like to mention, it's also for that a mother and a father should know how to do CPR if they have a newborn baby. Unfortunately, it happens that sometimes babies, for whatever the problem might be, stop breathing or go into cardiac arrest, and you don't have to wait till 911 arrives. So you need to do that. So you've got a very tight window of few minutes. Within 5 minutes, you've got to start CPR, hopefully even sooner. And then when the paramedics arrive, hopefully that's fast. It is fast if you're in a big city, usually. If you're in a rural area, of course, it can be much more difficult. And so continued CPR is more important. And you do CPR. If you have a defibrillator, you use it. If it doesn't work the first time, you do a second defibrillation and maybe even a third. And when the paramedics arrive, obviously they take over. They don't have to continue.
Can I add something to that real quickly, Lyn? Sure. And this is for those who are not familiar with the defibrillator. I am, because of the training that I've had as a health and fitness professional. Typically, there is a voice prompt for many defibrillators that will allow the bystander, if they are the only ones using it, to guide. So I want to let the viewers know that it's directional. They all come with the voice prompt, so that way you know how to guide.
Right. Mm-hmm. And even though it's very easy, as I said before, it's important to take the course with the Red Cross, because you see one, then you can do one. If you haven't seen one or practiced one, it's that more difficult, and it's critical for saving a life. Once the paramedics arrive, they usually use a breathing bag, so they're not doing mouth to mouth. And obviously they are very experienced in doing chest compressions. There are little devices now available. Some use them, some don't, for assisting chest compressions as far as the depth. It helps, you know how deep you're going. And they're automated devices. If paramedics don't always have them, some people don't like using them, like a chest thumper. It's sort of like an automated pair of hands that squeeze your chest, and you have to be on a solid surface, of course, to do that. So let's say the paramedics arrive, they do good CPR, and they defibrillate, but they still can't get your heart started. They continue CPR, they try another defibrillation, maybe they'll do 3, they can't get your heart started. In this day and age, that's it. There's nothing more they can do. 2, 3, 4 times defibrillation, they can't continue mouth to mouth forever in the field. So you're pronounced dead. And that's what happens most of the time. That happens almost all the time for trauma victims who go into cardiac arrest because of blood loss. And it happens, 85% of the time for sudden cardiac arrest outside a hospital environment. So in the future, I don't want to say this is ready now because we're doing clinical trials of EPR, rapid profound hypothermia, at Maryland Shock Trauma in Baltimore. But in the future, we would hope to move it from a hospital setting and make it available for paramedics to do. When CPR was first fully integrated by Dr. Saffer and introduced for paramedics to do, prior to Dr. Saffer, there weren't really paramedics. He trained really the first paramedic service in Pittsburgh. And when that started, a lot of people said, well, you can't have, paramedics do defibrillation, because defibrillators were really only available in the mid to late 50s, for paramedics to use. A lot of stuff had been experimental prior to that. And CPR, it was really only started in the late 50s to early 60s. When CPR got started, there wasn't no 911 to call. If people had an emergency, they'd call the police. It was due to Dr. Saffer and CPR and paramedics that really 911 got started. But
and then I remember that there was, growing up and going to school in the 70s, going into 80s. I'm 50 years old. And of course, there was then the emergence of teaching school children the concepts behind it. I remember CPR Annie, and I remember the mannequin that was made available in school as I was going through grade school and beyond. Right. So then there became an emergence of the need to know so that we can help save lives.
The first mannequin was called Resuscitation, and that was put together by Dr. Saffer's request for a Norwegian company called Lærdal that made baby dolls at the time. Now they just make medical equipment. But and there's a mini CPR doll that Lærdal makes for children to practice on. Not that they're going to do CPR, but in schools, even in elementary schools, it's very important for children to be exposed to what CPR is and what it's about. And they will go home to their parents and say, do you know CPR? And so it's encouragement for everybody to learn. So that's important.
One thing I do remember is that as I was going through the very first time in the beginning of my health and fitness career, that one of the things that was helpful in terms of the cadence and keeping up the time is say if you were giving chest compressions, for example, for the chest compressions to the breaths, that you think of like Staying Alive, the song Staying Alive by the Bee Gees. And so if you can think of that tempo and how fast that beat is, that it is pretty close to the rate of compressions that a bystander were to give. And so have you come across that little trick to make sure that compressions are given for the bystander in that space?
Yes. I've heard of that. Yes.
So real quickly, we're going to go ahead and go to commercial break. We've got so much to cover. We will be right back after this. Don't go anywhere. We will be right back after this.
Welcome to E360 TV, the live streaming and on-demand destination for influential voices and enlightened audiences. We offer trending, grassroots, and purpose-driven content across a diverse range of interests. E360 TV is more than just watching programs. We offer the ability to interact with live shows connecting audiences to real, authentic influencers and storytellers while streaming to millions of devices. Real experiences. Raw conversations. One destination for it all. E360 TV.
There's a type of workout that has been in the spotlight for some time, and many people are familiar with the phrase HIIT workouts, also known as high-intensity interval training. Now, what this is several rounds of exercises that alternate between several minutes of high-intensity movements to significantly increase the heart rate to at least 80% of one's maximum heart rate, followed by short periods of lower intensity movements. Now, this type of workout is considered anaerobic, meaning they don't rely exclusively on oxygen. Rather, the workouts are fueled mostly by stored carbohydrates. Now, I'm pointing this out because HIIT exercises make you breathe harder than steady state cardio exercises. This also increases cortisol levels in the body. And although the idea is to burn more fat on the body, as we get older, too much cortisol can produce symptoms of overtraining, which may include chronic fatigue, changes in sleep patterns, feelings of anxiety, or even a repressed immune system, to give you a few examples. Maturing bodies respond best to LIST exercises, otherwise known as low-intensity strength training. LIST exercises places the overall focus on strength training, the primary physical activity that promotes muscle mass preservation and bone mineral density production. This helps us slow down the rate of decline of bone mineral loss and muscle mass loss, which happens as we get older. Now, there are a lot of factors to be considered with the overall picture looks like, but this gives you a general idea and guidelines to keep in mind. If you are of an older age and you love HIIT workouts and you have no medical limitations and you've been cleared, feel free to incorporate them in your workout routine. It is recommended to keep the primary focus on the strength training, that you're doing that more so than the latter. And this is your Fit Bite for today. Welcome back to the Health Revolution. Welcome back, everybody. I'm your host, Adriana Morrison. We're talking today about saving lives. And one of the things that I do want to bring to the attention of viewers is that, of course, many may recall that Buffalo Bills safety Damar Hamlin had suffered a cardiac arrest a little more than a year ago, and it was broadcast live on television. And so the emphasis of me bringing this up is the importance of time, how quickly the trainers got to him, brought him to the hospital, and they initiated life-saving procedures, which allows me to segue into our continued conversation with my guest today, Dr. Lyn Yaffe, who's the CEO of EPR-Technologies, and Lyn, I know Dr. Yaffe, either or. I love this conversation because it places the urgency and the intentionality behind quality of care and life-saving approaches. Can you speak a little bit about what you witnessed in Damar Hamlin's life-saving procedures that so many of us saw on television worldwide?
Well, I'd like to say, obviously, the importance of training. I mean, and his life was saved by experience of the trainers and the paramedic experience are there. You know, in relationship to that, I'd like to say how EPR, rapid profound hypothermia, also has a sort of model in the real world, even though it's not FDA approved to be done other than our clinical trial, as things have to be done. There are situations where a healthy skier in the mountains is covered in a sudden avalanche. And these cases have been reported in the medical literature. And so that's a healthy person, assuming skiers are healthy. They get covered in an avalanche and their body cools down so quickly, covered in that cold weather, that they've stopped breathing. There's no heartbeat. They essentially would appear clinically dead, but there's still cellular life because their metabolism has been reduced to the point that they don't need any additional oxygen, just like we're trying to do clinically in EPR. Now, the rescuers, there are cases where rescuers find those skiers and they dig them out, and obviously they're unconscious, there's no heartbeat, there's no breathing, and they rapidly rewarm them. I won't go into all the techniques. They rapidly rewarm them and do CPR, and lo and behold, some of those skiers are saved. Not every situation, but that's sort of a real life situation where rapid profound hypothermia has occurred because of the avalanche, and then the people can be resuscitated afterwards. It's also, there's some cases in the literature where small children fall into a lake that's frozen over, so the water's obviously very cold, and they cool down so fast they don't need oxygen because their metabolism is lowered. The divers find them and they get rewarmed and resuscitated. So rapid profound hypothermia in and of itself isn't incompatible with life. It's clearly compatible with a recovery if everything is done quickly. And that's what the clinical trial is about, going through those steps and demonstrating to the FDA that this can be done in the laboratory.
I'm sorry, I don't mean to interrupt. I was just curious.
No, go ahead. I've gone too long.
The initial conversations of EPR and what it stands for, what was the reaction that you all have come across in talking to colleagues and getting this off the ground, getting the ball moving for this to move forward?
Yeah, I mean, obviously trained trauma surgeons at the major trauma centers in the US, of which Maryland Shock Trauma is a premier trauma center, they're all very interested, and they know that this is a technique that will save lives. When we first got money from the military for doing the clinical trial, 7 major trauma centers wanted to participate, but we only had enough money for Maryland Shock Trauma. For the public, you know, we had to have sessions to demonstrate and to get buy-in to do this, because for a clinical trial, you need a patient's consent. But if the patient's unconscious and the family's not there, you need public approval to do this. And so you have to, interact with the public in a very formal way for the university, for Maryland Shock Trauma to get approval. And a lot of people thought, well, this is like resurrecting someone. And so, we always want to point out that we're not resurrecting the dead. We're preventing someone from dying. We're maintaining cellular life. And
now, I do have a quick question. Is there a time period in which is ideal for when someone suffers a cardiac arrest and so then the hypothermia effect is happening and their body is cooling? Is there a window, an ideal window period in which for all of this to take place?
Yeah, let me describe the clinical trial, not what may happen in the future in the field with trained paramedics to do this. So for the clinical trial, we have to follow the strict protocol guidelines that the FDA has approved. And in those guidelines, we can't take someone who goes into cardiac arrest at the scene of the accident on the street. They have to go into cardiac arrest after they arrive at the trauma center. So if you have a patient who's been in a serious automobile accident or a gunshot wound, unfortunately, and they're bleeding heavily, but they don't go into cardiac arrest yet. The paramedics arrive, They take them to the hospital by helicopter or ambulance, depending how close. And now the patient still has a beating heart. And but on the table for whatever surgical repairs might be needed, they unfortunately then go into cardiac arrest after they've arrived at the trauma center. Now that patient can be a candidate for EPR if the CPR doesn't work. And the reason they have to go to be in the study, they have to go into cardiac arrest at the hospital, because we have to know when time zero is. We have to know the good CPR is done at a trauma center, because we're interested in how well the brain is doing in CPR and EPR. So let's say you're a patient who's lost a lot of blood. You're on the surgery table at the trauma center. You go into cardiac arrest. Okay. They will do CPR. They'll do CPR for 30 minutes. They've got you're intubated, breathing is no problem. All the trauma surgeons are there doing cardiac arrest, chest compressions. They will defibrillate as necessary. And they may work on you for 30 minutes with repeat defibrillations. If they can't get your heart started, they'll do a left thoracotomy, where they'll open your left chest, separate the ribs, and with a gloved hand, they'll manually massage your heart to see if they can still get your heart started. Let's say they've done something to stop the bleeding by then, and maybe they're giving you fluid, maybe they're giving you some blood. So they manually massage the heart, and they can try and defibrillate again. If they can't get the heart started at that point, well, then you're a candidate for EPR. You've had good CPR. So, they're not as worried about the brain. You've had oxygen delivery. They've been pumping blood or blood that they've given you around, but you still go into cardiac arrest, and they can't get your heart started. Then they say, okay, let's do EPR, which means they rapidly cool you down. And they do that by putting an ice cold, 1 to 2 degrees Celsius, ice cold saline, physiological saline. They pump that into your body. I won't go into all the techniques, but that flows through your body and it cools your entire body down, your vital organs particularly, and your brain. It cools your vital organs down to 10 degrees Celsius, 50 degrees Fahrenheit. So then they don't have to worry about giving you oxygen anymore. Now that takes 5 to 7 minutes. They rapidly do a cold flush, so you're cooled down in, let's say, 7 minutes to target temperature. And so now you're lying on the table at the trauma center. They don't have to worry about resuscitation. They can do surgical repairs now, whatever the problem was. In the clinical trial, we don't use anyone who has obvious head injury, because we don't want to complicate. We're to demonstrate that rapid profound hypothermia can save a life. So we don't want to complicate things. We don't do this on a 90-year-old or on a child.
What's been, when did the clinical trials begin? And I know that they're ongoing because...
Right, the clinical trial started before the COVID-19 pandemic. And during the pandemic, it was on hold because we use a lot of blood when we start to rewarm the patient. We have to give them blood back because we've flushed out their blood with saline. So we use a lot of blood bank blood. And during COVID-19, a lot of people who were in respiratory difficulty, they also used what's called extracorporeal membrane oxygenation. And that requires a lot of blood. So they had so many people at Maryland Shock Trauma and other centers around the U.S. needing blood, particularly Maryland Shock Trauma. We put the clinical trial on hold because people weren't donating blood during COVID-19. It's sort of getting back to normal now, but still, I think there are 1,000 people a day. Aren't there 1,000 people a day still dying from COVID in the U.S.? I tend not to check. But so we were on hold during the pandemic, and it's recently restarted. And we're sort of, the team has gotten trained up again because, some trauma surgeons, they leave or they go to other institutions, and this requires a trained team. So
and you brought up something fascinating to me, and that's it seems like all the players, all hands on deck, have to be in place in order for the clinical trials to run. So I'm thinking not only the trauma surgeon, but then, obviously everyone who is there. And so then the communication has to be extremely clear with, I would imagine, paramedics and
Right.
all of that, right?
There's a specific, at Maryland Shock Trauma, there's a specific team that is trained to do this.
Okay.
And if you're a candidate for EPR, meaning you got to the hospital and CPR failed, and you go into a cardiac arrest and they can't resuscitate you and you're candidate for EPR, you have to be lucky enough that the trained EPR team is on call, that they're there, that it's not on their day off, so to speak. So, this is not like a cancer drug clinical trial where you can immediately recruit 300 patients who have that particular cancer and you can try this according to the guidelines. So
I
we
would
do
imagine. I would imagine that
reduction.
the manpower behind the clinical trials is still emerging as you continue to, fine tune and move forward with the
Yes,
trials,
yes.
right?
Well, they have a trained up team, and when new people come to the team, they usually practice on a pig. A lot of the animal studies were done on pigs and rats. Pigs are good models for human beings, physiologically speaking. But the complexity of doing this, and I want to emphasize that currently it's a complex procedure at a trauma center. But one of the goals of the company is to simplify this and make it as automated as possible. I won't go into all the techniques. There's no time. Using artificial intelligence and automatic placement of catheters for the cooling, and how this is done so that a paramedic will be able to do it. Just as I previously said, when CPR got started, some people said, oh, paramedics or ambulance drivers will never be able to do all of this with defibrillators and whatnot. It's true. Now bystanders can do it if they have the equipment. And the same will be true for EPR, rapid profound hypothermia. To do it will get simpler and simpler and simpler. And maybe in the future, surgeons and trauma specialists and even paramedics will say, well, let's not wait until this person goes into cardiac arrest because of the severity of their injuries, and let's not do CPR for 30 minutes. Let's do EPR as soon as possible and not risk them being deprived of oxygen for any prolonged period of time before we start EPR. The idea is to maintain good oxygen supply to the brain. And if you can't do that for your vital organs, cool them down as quickly as possible. So that'll happen over time. I mean, we're on we want to fast track this, obviously, as quickly as possible to save lives, not just in the U.S., but around the world. There's so many lives that could be saved. Unfortunately, in the U.S., gunshot wound victims are on the rise. Obviously, automobile accidents are still the major killer, but at least there are things that can be done if you're a safe driver and you're wearing a seatbelt and
I love
airbags.
I love what this is doing, because this is really truly giving more options to, for moments. And obviously with cardiac arrest, with more people on the planet, which means that the rates of cardiac arrest are also exponentially climbing as well. And so what is your goal? Before we go to commercial break, how do you like to get the word out when it comes to what EPR-Technologies has to offer?
Well, we have a website, www.epr-technologies.com. I do some podcasts, and we have press releases. We're on the verge of a substantial investment from investment groups. EPR is a high risk for investors, so it's taken us a while to, find investors that want to take the risk. But we think we found them, and the techniques what they're using that we're going to use, they find intriguing. Up to this point in time, it's really been the U.S. taxpayers through the Army Medical Research and Development Command has paid for, the animal research and the clinical trial, because right now the military, they don't have an alternative for people who are who are injured on the battlefield. I mean, the military medics are there, and they have a lot of surgical, at the battalion aid stations. If the casualty can survive, the initial 30 minutes to get there, they can get them on the battlefield. But we want to make this so simple that it can be done on the battlefield by a military medic and also by paramedics. So it takes a lot of automation.
Lyn, hold that thought. We're going to go to break. I want to continue this conversation for sure. We will be right back. Don't go anywhere. Don't go anywhere. We will be right back after this. Thank you so much for watching The Health Revolution. Our show is growing, and it's all thanks to viewers like you. No matter how you found us, please hit the subscribe button so we can stay connected and continue to deliver amazing content to you.
Life is so fragile, and we're constantly reminded just how fragile life can be, especially when we or a loved one is told we have cancer. Cancer survivor myself, I can tell you, we still feel very alone in this journey.
There's a study that's been showing that patients who are socially isolated have a worse prognosis, have a worse outcome than patients who are socially interconnected.
Buddies for Life is a non-profit cancer support group for those whose life has been impacted by cancer. Humor, hope, heart, and hugs.
Humor, hope, heart, hugs, and a whole lot of love.
Share this with your friends and family and support this community in every way you can. No one should face cancer alone.
I am a chemo buddy for life.
We are a buddies network.
No one does cancer alone.
Be a buddy.
And we are all here for you as a community of love.
We are chemo buddies for life.
And if you've heard 3 words, you have cancer, for yourself or someone else, you belong with us at Chemo Buddies for Life.
Healing through connections.
And now we want to give special thanks to Biomed Mobile IV for sponsoring the Health Revolution. Biomed Mobile IV is Colorado's top mobile IV therapy service, servicing throughout the state of Colorado. They offer an array of vitamins and above and beyond safety preparation. Biomed Mobile IV, your dedication to health and wellness is exactly what our show is all about, and we thank you for your support. Welcome back to the Health Revolution. We're back, everybody. My guest today, Lyn Yaffe, CEO of EPR-Technologies, and we are talking about all things in enhancing technology for saving lives. And Lyn, one of the questions I wanted to ask you, what were some of the breakthroughs that EPR-Technology has experienced in this type of technology? What are some of the milestones, the wins that you've encountered along the way?
Well, some of the things that we'd like to do and we're able to do, we cannot do in this initial clinical trial because the FDA requires, the idea is test one variable at a time. You don't give a cancer patient 3 different, treatment options all in one study. And so, it's important. What I'll say right now in the clinical trial, we use ice cold saline, but we have additives that will enhance things that we'd like to add to that cooling agent. So we can't really test that just yet, other than having been tested in animals. It's clearly beneficial. The FDA just wants to show that cold, profound hypothermia, is safe and good, and then they'll let us enhance things probably with subsequent clinical trials. There are also some automated visual techniques that we've developed for catheter placement that makes it possible to gain access to the aorta, the large vessel coming off the left ventricle of the heart, in an automated way, so you don't have to do a left thoracotomy. You're not going to do that in the field, to make it easy to do that. And artificial intelligence will enhance that capability. So we've made some very interesting progress in terms of cooling solutions and the techniques for making it easier to do this. And that's really our goal. Those will require, I'm sure, additional, not full scale clinical trials, but clinical trials of some sort to demonstrate to the FDA that those are enhancements.
Is there criteria for full scale clinical trials?
Well, the protocol for EPR is on the FDA approved protocol is on the internet. If you go to I can't remember exact site, but if you look up, let's say, FDA approved clinical trials, there's a government site, FDA, in Google, FDA approved clinical trials, and then it'll take you to a .gov site, and you can type in the EPR-Technologies, and you can see the protocol of the clinical trial. And there's a lot more mentioned on our website as well. And so, this is an ongoing, the initial clinical trial. And you said, how do we get the word out? Well, when we've had a lot of news articles, and aside from podcasts and things that I've done recently, there have been a lot of news articles. There have been local news coverage, like NBC in Baltimore had a segment when the clinical trial got started before COVID. And there have been, I can't remember which magazines it's been, like Scientific American, it's been mentioned in. So we have that. And a lot of paramedics know about it because, people in the field keep up to date on things. Certainly trauma surgeons all know. But we'll go to trauma conferences, and paramedics have conferences. And, we'll have continuing medical education.
That was my next question is, are there conferences that you're planning on being at?
Oh, absolutely. Absolutely. If you go to a medical conference, and let's say a surgery or a trauma surgeon conference, in the aside from all the talks that are given, by researchers and other, in the main convention hall, all of the medical device companies and pharmaceutical companies, whatever they feel they want to promote to trauma surgeons or paramedics, they'll have booths set up, like at the Las Vegas, Electronics Association, where they show their new technologies, new flat screen TVs.
Is there any specific conference that you are planning on attending, or the EPR-Technologies is planning on attending in 2024? Is there any that for sure?
We haven't specifically signed up for one, but there is a trauma conference every year in the U.S., and then there's a European one. There are conferences that are in China. Not that we're immediately planning that, but and there are paramedic EMT conferences every year, and there are device conferences, let's say for radiologists, where it's good to show this kind of equipment, and for cardiopulmonary bypass equipment. There are conferences, and obviously research conferences we would attend. And for some of our additives that I won't go into, having to do with delivering oxygen during the cool down, there are conferences specifically for that. So, you could almost go to a conference on a weekly basis if you wanted to. And we'll have a team of people to go to the key conferences, set up a booth with demonstrations and videos, and showing our equipment, as every company does.
So then, obviously, that's something that's going to be that is a very likely thing that's going to take place.
Right.
So for
that's
anyone
for professionals, it's also, as you've said, getting the word out to the public is also important. So this is not something strange to them. The public knows about CPR, and over time they'll know about EPR through appropriate coverage.
Absolutely. We've got to take a quick break. We're going to be right back. Hang tight. Don't go anywhere. We will be right back after this.
Greetings, I'm Angel Marie Monticelli, host of Energize You TV, every Thursday at 11 a.m. Pacific time. Go to Fresh Takes right here on E360 and get Reikified and energized today.
Welcome back to the Health Revolution. We're back here on the Health Revolution. My guest today, Dr. Lyn Yaffe, the CEO of EPR-Technologies. They are advancing the paving the way and enhancing saving lives with their innovative technologies. And Lyn, where can everyone find you? Where can everyone find EPR-Technologies?
Well, I mentioned our website, www.epr-technologies.com. It's also, if you go to YouTube and you type in EPR Technologies, or you type in my name, or you type in Peter Saffer, that interesting history, you can type in Resuscitation and read about that. You can type in CPR, and you can type in Freedom House, which was the first paramedic service in the U.S. developed by Peter Saffer. That's an interesting history. So all of those terms in YouTube, and you can also go to Wikipedia and look up Peter Saffer, or you can look up the history of cardiopulmonary resuscitation.
And then also on, how about social media? Where is EPR on social
We're
media?
on LinkedIn. We're on Facebook. I've been planning on Instagram and TikTok. I haven't done that yet, but we'll do that soon. Let's see what else. I think that's it for social media. But there is a lot of things available, and press things that you can also find on YouTube and EPR.
So obviously for viewers who are wanting to tune into upcoming information for EPR Technologies, obviously the website will have.
Yes, if you go to the website, there's at the top line, there's a button about podcasts and webinars. And if you click on that, you can see some upcoming webinars and reserve a seat, for a future date if you want to do that. They're all free of charge. You just have to find the time.
Lyn
Last
Yaffe,
thing I always like to highlight is encourage everybody to learn CPR and the use of the defibrillator. It doesn't take very long at the Red Cross, and that's let's say the forerunner for the paramedics to then come in and do EPR.
Absolutely.
One last thing I should say.
I wish we had a whole lot of time,
Okay.
and we are running out of time, but
Thank you very much.
Obviously this is indicative of how important this is. And I can't thank you enough for being on our show and explaining where this is going and why we need to pay attention to what the incredible work that you are all doing. So thank you so much for being on the show.
Thank you. It's been a great pleasure.
Yes, and for all of you viewers, as you are tuning in, please do not forget, you can always reach out to our website at thehealthrevolutiontv.com. You can always find our updates, and you can subscribe to our newsletter to see what's happening. In addition to that, if you have any ideas for show topics, we would love to hear from you. And if you have your phone out ready, you can go ahead and take a quick snapshot of our QR code. So that's a quick go-to as the crow flies. And then don't forget, in terms of when we are on every Tuesdays and Thursdays on E360 TV at 10 a.m. Pacific, 1 p.m. Eastern, right here. And that is all the time that we have. Thank you so much for joining us. Very important information we're covering. And without further ado, of course, have a great rest of your day, evening, no matter how you're tuning into. Thanks for watching the replay. If you caught the replay, we'll see you next time. Take care.